Good evening, everyone, and welcome to the second session of the Master Trainer program. Today's topic of discussion is very basic, and some of you may find it that's something that you're doing every day. But the idea of keeping this as one of the topic of discussion is that we all have to remember that not only we have to communicate effectively, but we also have to train our people to communicate effectively. So the focus of today's session will be basically working on our verbal and non-verbal communication. So again, as I normally say, I will not be using much of theory, but I'll help you learn through experience. So we'll be doing a lot of activities to understand how we communicate and how communication, misfires and how things can go wrong. So to start with, I will be showing you two videos. Fortunately, these videos have been done by Indian doctors. So they're very simple. You will be able to relate with them very well. What I want you to focus on or observe is the body language, the tone of voice, selection of words, so that we get an idea where are we going wrong or right. So the first video will be like normally what we see very often, and then it will be followed by a better version of it. Could we have communicated in this manner? So let me share the screen and show you the video, and then we have a discussion. But meanwhile, when you are seeing the video, you can keep noting down the points in your notebook of whatever you observe. And then I will request each one of you to give 1 point so that everybody is able to contribute. Give me a second to show you the video. So I hope the screen is visible to all of you.
Yes, it's coming black, but the screen is visible.
Yeah. It's still to start, yes.
Next. What? Doctor, my leg is swollen and painful. For the last 5-6 days. What were you doing? Why did you wait so long? This looks pretty bad. Doctor, I thought the pain was just a strain in the leg. Anyway, what do you think now? You could have waited for some more time and we could have amputated your leg. Leave it. What's your sugar level? It is under control, doctor. The fasting was 140. When was it done? What was your HbA1c? It was 4-5 months ago. Actually, HbA1c is an expensive test and I was feeling all right. I can't understand. You do investigation according to your will. You don't take proper treatment. You don't follow our advice. I don't know why you need doctors. You come up with all sorts of complications like this. And what did you do with your leg? I went on a pilgrimage to Sabrimala, so had to walk barefoot. I might have injured, I think. Barefoot? Hello? Yeah. Who? The patient Ram, HIV positive patient. So he doesn't want CT scan. See, tell him if he wants treatment, he needs to undergo CT scan. Like, what does he think of himself, yeah? Prime Minister or President? See, discharge him against medical advice and tell him not to come to this hospital once again. Okay? Yeah, bye. And you got this boon. I'll tell you, if you go once again, you will also go near the God. Didn't I tell you about the foot care when you came last time? Huh? And your smoking is continuing without interruption, I guess.
I've reduced a lot, doctor. I am smoking only 1 or 2 cigarettes a day now.
And understand your attitude here. You do smoking, you are overweight, you don't take medications, you don't do investigations. I don't know what to tell you.
I'm trying, doctor. And if you don't want to see me, I could consult someone else.
See, whatever I'm telling is for your good. I don't know how to tell. I gave you information leaflets last time and you're not following my advice. And if you don't want to see me, it's fine with me. I have got enough work to do. I've got enough patients to see. Sister, please call the next patient.
So what is the observation?
Can I?
So maybe if you raise your hand one by one, maybe virtual hand. So that way I will know whoever wants to answer first. Virtual hand. On your right hand. Yeah, thank you. Yes, Lavanya. Okay, so Lavanya and then Aparna and then Dr. Vijay. Yeah, Mr. Vijay. So Lavanya, go ahead, please. Good. Tell me. And 1.1%, I want everybody to give one observation. Yes, please, go ahead.
So, ma'am, one thing that I noticed here is privacy, breach of privacy. He named the patient, then HIV ke report bhi bata di.
Absolutely. So patient's confidentiality was, compromised, which is legally also, not acceptable. Thank you, Lavanya, for pointing out that. Yes, Aparna, I think.
Yeah, ma'am. So here the collection of words, like as you mentioned by the doctor, was what were you doing till this time? And he also mentioned आपको amputate कर देंगे आपको.
Okay.
So
he used threat.
That was a shock to the patient.
So that
he
means
felt that why did I come to him? I should consult some other doctor.
Absolutely. So he was using threat to get compliance.
Yeah, exactly.
Thank you. Yes, Mr. Vijay.
Doctor's conversation was not at all comforting.
Mm-hmm.
His voice, his way of talking was, scary to the patient.
So he was using threat. He was not, it's not only not being friendly, but being actually intimidating to the patient. Absolutely. Yes. I agree with you completely. Yes, Dr. Abhishek. And then Anandita and Dr. Somnath. Yes, go ahead, please.
I think he was just not invested in the patient's problem. In the beginning itself, when the patient started talking, he was not even looking at him. He was looking elsewhere. And then he was distracted and a very condescending attitude.
So Dr. Abhishek, although he could have been actually looking at the patient's case sheet to just see, what the patient's details are. But if you don't give prompt attention to the patient gets a feeling that you are distracted or you are busy doing something else. I completely agree. And also he was very condescending. I absolutely agree with you. Yes, Anandita, please go ahead.
As per me, the initial patient connect itself was not built. So when he asked whether he can come in or not, he didn't even have an eye contact, which is very important in any communication. Absolutely. And he seems to be overconfident, and that connect was only not created. So that was my viewpoint.
I completely agree with you. I think the initial connection was not formed because he did not even look at the patient. He did not make eye contact. And the way he called, do you remember the first word he called? What did he say? Next.
Next. That's so the patient didn't have a name, rather as a kind of quantity or maybe a item.
Just a one odd person. Yes. And also, what was the first word, if you remember, that he spoke to the patient? Anybody else? Not Anandita, somebody else. What was the first word Ravinder, do you remember the first word?
I don't see now writing the next.
Tomorrow Hindi, right?
Yeah.
Tomorrow Hindi, right?
Yeah.
Okay.
I don't
Tomorrow is
remember exactly, but I could make out
Saturday
that
is
there was
last.
Yeah.
Somebody
Saturday
request.
Talk.
Yeah, yes, Ravinder. Do you remember the first word that he said?
it was, as far as I remember, one thing which I observed was it was lack of eye-to-eye contact, and there was no consideration of, like when he talked about economically, he's not able to afford
Yes.
or reducing cigarette. There was no consideration on his efforts being put in or considering the financial problem which the patient might be facing.
Absolutely. So there was lack of empathy when patient said that it's an expensive test and I couldn't get it done. Absolutely. I completely agree. The first word that he said, what?
What?
Remember, the first word he said to the patient was what. So when you talk like this, I'm sure the patient will be, first of all, shocked now. How do I start and what do I start from? Absolutely. Yes, Dr. Somak, please go ahead. Yeah.
Yeah, he just called next, and then as the patient entered, there was no eye contact. There was no non-verbal. The non-verbal communication was not so good.
Mm-hmm.
He was not connecting with the patient, and he just he didn't bother. He didn't give the basic respect of another human being. Forget about being a patient or doctor or anything. And then he was looking at the phone and paper, and he was expecting him to tell the complaints.
Yeah.
And without even engaging him or taking an elaborate history or anything, he started threatening him, if you're going to be like this, you will lose your limb. You could have amputated your limb.
Absolutely.
And the worst thing was, if you go to, next time, if you go walk to barefoot, you will go to God directly.
Yes.
So that was an...
so you are making mockery of patients' religious
yes.
beliefs.
Yeah, so that's a big no-no. And then when the patient was talking about HbA1c or fasting, the HbA1c is expensive. He could have told it's okay. There's no need to do HbA1c. If you keep your fasting and postprandial under control, you can check it. So there are many ways to put it. And then maybe instead of every 3 months, he can take it for every 6 months. You can do it depending upon his financial status. And when you are consulting a patient, in between he talks to the phone and says he's HIV positive, and throw him out of hospital, discharge him AMA, and ask him not to come back to the hospital again. So that gives an indirect feeling. If I go to that doctor, I will give that. If he's treating other patients like this, I will also get the same sort of treatment.
Absolutely. So that
so
means
I will not
I also talked about in my absence. This is how the doctors will talk about me in my absence. Absolutely. So I want those who have not given any point to share your thoughts. Simil, what is your thought? Dr. Samaji, what did you observe in the video? What do you think was inappropriate?
Actually, sorry, madam.
I joined little late, so I couldn't hear the initial conversation. But later on, I found that the doctor was really rude.
Very rude. Absolutely.
And the patient was some sort of embarrassment I could observe in his face.
Facial expression. Absolutely. Yeah. You are very right. Yeah. Dr. Anu, any observation from your side? What did you observe?
Greeting and welcoming the patient itself is not a friendly atmosphere. He didn't give any option for him to say his concerns. And empathy is absolutely missing. And deviation, he is deviating by his calls, and he is talking rude about one patient in front of this patient. And in one conversation, he asked himself, like, what would have been happened to you? Like, he is asking diagnosis to the patient itself. And even if he needs amputation also, he would have conveyed in another way, which is missing here.
And in between, he used one word. So you got this boon.
Yes.
I mean, saying something
the doctor was trying to feel the patient guilty.
Make the patient feel guilty. Absolutely. I completely agree. So friends, I don't mean, yes, Dr. Purnima, please go ahead. Yeah. Go ahead, please.
Seems to be some problem that I'm not able to raise the hand. But just thought that he also made some politically wrong statements by commenting upon the religious sentiment of the patient. And of course, the lack of empathy was there. And his attitude came across as critical, non-empathetic, and judgmental. And supposed to attend to the patient as a whole, and the patient's habits are part of it. There is no such perfect patient. So he basically came across as critical, overbearing, non-empathetic, judgmental, and politically wrong by talking about his religious sentiments.
Thank you for summarizing the whole thing. Thank you.
Just
Thank
one
you.
thing more.
Yes, Ramita.
That messages which were being given, it was more of negative message.
Absolutely, no doubt
If
about
you, like we say, if you do not do this, if you're doing that, will happen. Recover faster, and you'll be able to get out of this problem.
Absolutely. I completely agree with you. So, friends, I don't think any one of us would go this wrong. Nobody will accept that, okay, this is how I treat my patient. But we must be doing something similar to it, maybe a subtle form of it, not all of it. And not just with patients' family members, with our colleagues, especially with our juniors and subordinates, whom we know we can talk the way we like and they cannot give us back. So this was just to give you an idea of how we fail on our body language, verbal expression, tone of voice, selection of words. And I think you will be able to relate with this video when you will look at a broader picture. So even if you are not a doctor, if you're a nurse or an administrator or a HR personnel, I'm sure you will be able to understand that we do these kind of failures with people with whom we work, and especially if we know they cannot give us back, they cannot illiterate us. But I think in this video we got an idea how we fail miserably when we don't greet people, then when we are, and the body language, the facial expression, the neck, the stiffness of the neck, the look on his face clearly showed that he was very intimidating and very aggressive with the patient. And when in the end he said, whatever I'm saying, it is for your good. So he was acting more like an authoritative parent. And this is what we tell to everyone when we find their fault and we try to show them that you're wrong here. We say, I'm saying this for your benefit. But my dear, if your tone of voice and your expression is not right, then please accept that nobody will accept your intention. Nobody will believe your intention. You are hurting the person by insulting, by belittling, by demeaning. How will that person accept your intention or your words? Dr. Vijay, do you have anything to add here?
Ma'am, actually, I missed the initial part. I came a bit late, so I was just observing what you are going through. That's all. I'll be joining the next.
No problem. So we have actually seen one video where we tried to see the behavior of the interaction between the doctor and the patient. But that's not just limited to the doctor-patient communication. I think this is communication between us, with our team members, with our juniors, with our co-workers, with patients, and with their family member. And it is not just the doctor. It could be the nurse, it could be the administrator, it could be the quality professional, or anybody who is working in the healthcare. So it's all about that. So we were trying to very closely see the behavior and overall interaction, and we could identify a lot of errors in that communication, where we looked at the language and paralanguage and body language and all those aspects. So now let's look at the second video and see, could the whole communication be done in this manner? Let me share the second video with you. This time I want those who have not given any feedback to now give their feedback on what have they observed. Give me 1 second to show the video. And please note down in your notebook whatever you observe.
Next. Hello, Mr. Kannan. How are you? Please take your seat.
Thank you.
What can I do for you?
Doctor, I think I have a problem with my leg.
What happened?
4-5 days back, I went to Sabrimala and I had to walk barefoot for some distance. I'm very scared now because my leg is swollen and painful in the last 4-5 days, and I think I did a stupid thing by walking barefoot.
Let's see what we can do. Good that you realize the importance of foot care. Meanwhile, how are your sugars?
Actually, my fasting sugars were 140, but it was some months ago. I was feeling all right, and I didn't do the HbA1c. It is so expensive, you know.
It is expensive indeed, but so important to get the investigations prescribed by the doctors, because otherwise it's very difficult to give the treatment, you know, and treatment may not work as well. Anyway, can I examine your leg?
Yeah, sure. Sorry, sir. It was my mistake. I didn't do the test.
Hello? Yeah? Yeah. Excuse me for a moment. Yeah. What's the name of the patient? So he doesn't want the CT scan, right? Yeah. Try to explain to him the importance of CT scan. Yeah, when I come for rounds, I will also tell him. Okay, thanks for informing. Thanks, bye. Sorry about that. You got infection in your leg. So how are we doing regarding the quitting the smoking?
Regarding smoking, it's doing good. Actually, I brought it down to only 1 or 2 cigarettes per day now, doctor.
That's good. But total quitting is very important. See, if you have reduced from 1 pack to 1 or 2 cigarettes per day, quitting that is also not very difficult, you know. And how are we doing regarding the exercise?
Yeah, going on, but I must admit not so regular.
See, exercise and diet are as important as your medicines, if not more. But for the time being, you need admission for sugar control and control of this infection. Is it okay with you?
Whatever you say, doctor, you have to cure me this time, and hereafter I will definitely take care of myself. This will not happen again.
Yeah, we need to control your sugars and control the infection. Otherwise, it may go for gangrene and may lead to further complications. Now, the sister will go through the procedure and admission process. Okay. And meanwhile, you have this leaflet and you can go through it, which will help you to follow the regimes. Okay, thank you very much.
Thank you so much, doctor. It was so kind of you.
You're welcome. Thank you.
So now I want to hear from those who did not respond in the last video.
Yes, ma'am. Shall I start?
I'll come back to you later. I want people who have not participated in the earlier video. Yes, Dr. Vijay, go ahead.
Yes, ma'am. I felt it's commendable way of consultation. So doctor was very much empathetic. He was with all manners. He was dealing with the patient. He was clearly listening to all the complaints. He was asking all the leading questions. Specifically, when doctor got a call from some lab or somewhere, he was asking for excusing, and after just briskly talking, he was apologetic to the patient for taking the time. And again, he was supportive with the patient. He was encouraging about quitting smoking. And when he said that he from 2 packets to 1 or 2 numbers, he was congratulating him and he was motivating him to quit smoking. And then he was very clearly explaining about the treatment modalities. And he was even asking permission whether will you have time to get admitted with the patient. So,
Dr. Vijay, can I stop you here?
Yes.
I want others to get a chance to share their learning. Thank you. I think you really summarized it very well. But I want Semil and then also Dr.
Can I
Sagar.
say?
Yes,
Can
yes.
I say?
Okay, yes, then go ahead.
The greetings were there in the beginning. There was greeting, there was care, there was concern. And the call which came this time, he was very careful the way he answered the call without taking the name of the patient. He was kind and considerate, and a lot of guidance was given by him to the patient.
I agree. Thank you. I think that was a very good observation. Yes, Semil, what do you have to add to it?
Here the doctor was entirely different. The previous doctor was negative, shown a negative approach. Here he was showing a positive and encouraging approach.
Absolutely.
The patient was feeling comfortable, and rather the patient himself has told, yes, I will change my behavior.
I think very right. Yeah.
Yeah.
He brought the patient to a point where patient was apologetic for his being negligent. Thank you.
Yeah. Okay.
Yeah. Thank you. Yes. Dr. Sambaji, go ahead, please.
Madam, doctor patient connect was very good. He listened his history properly, and his explanation about the patient costly test was very good. So and that made patient apologize his mistakes, and even in between he got a phone call that also he answered politely, and with that he explained the patient also in a nice way.
Wonderful. Wonderful. Anandita, do you have anything to add to what everybody has said?
Yes, for any communication, ma'am, to become effective, there has to be a good beginning and a good closure. So we follow here, like watching the video, that the beginning as well as definitely the message was conveyed well, and it was well received, and as well as the closure was also done effectively.
Very effectively. Absolutely. I think very good observation, Anandita. Thank you. Thank you for adding that point. Yes, Dr. Purnima, go ahead, please.
Everything has been properly, very nicely summed up. Thanks, friends. But I just had a single observation between the two videos. When we see the change in the doctor's attitude, find that the patient's communication is much more pleasant and accepting. As compared to the first video, the patient's version of telling his symptoms, he was accepting correction better. He was understanding better. He was more amenable to everything because he was mirroring the attitude of communication of the doctor. And the most important thing is that the affirmations that the doctor was giving, he was nodding, he was listening, his body language was open. So that probably contributed to him feeling safe enough to share. Thank you, ma'am.
Very right observation, Dr. Purnima, just right. See, when we are little rude, the other person is on the edge. They are on defense. They are actually anxious that they might be insulted or hurt or humiliated in front of others. So definitely they will be on guard.
Instead here the doctor was respectful in his words.
And therefore the patient also became relaxed and was open. So here I want to bring one point to everybody's, understanding. See, you may be seeing 10, 15, 20, 30 patients in a day. If not patients, if you're handling staff, then you are handling 15, 20, 30 staff in a day. Or if you are in indoor, if you're a nurse, if you're handling patients, or you're at a billing counter, I'm sure you are handling these many people in a day. So if you have a tendency to shout at people, Jenna, your video is shaking a lot. There's some challenge at your end. Is there a way to stop that? Otherwise, because it's disturbing me, because I don't have any notes in my hands. I normally speak from what the discussion is about. I really request you, although I appreciate that you were trying to keep your video on. Or you can join using the mobile in case.
No problem.
Thank you for understanding. So what I want to bring in here, that if you are in habit of shouting every day, if you are working with 10, 15 or 20 people and you are shouting at them, just imagine your mental health at the end of the day. And you must have seen people who are in habit of shouting, they would find a reason to shout. They will raise voice for any silly reason also. Then that becomes our nature. And then you're going to take this home to your family also. It's very difficult to be calm at one place and be very aggressive in another place. More or less, our behavior in both these spheres will be more or less similar. So imagine yourself over a period of 10, 15, 20, 30, 40 years. What will we be? And you must have seen seniors who were just not able to control their anger, and it actually aggravates with time. Higher you move, and if you are aggressive in nature, more likely you are to not only become more aggressive, but also, you can go to any level. Your language will go down, your behavior will go down, because then you are at a power position and you can behave the way you like. That's such a that's such a sad story. And imagine what you're doing to yourself. And the way you are using your body and mind, your intracranial pressure and your body muscle tension, I'm sure it will go, higher and higher every day. Also, let me remind you, patient compliance rate across the world is just 30-35%. It's not just in India. Across the world, if you will look for studies, you will get to see the compliance rate is just 30, 35, 40%, not much. So please don't think that Indian patients are misbehaved, or they are ignorant, or they are useless, or they are not following. Compliance to such strict regimes sometimes becomes very cumbersome. So we have to understand that compliance is poor across the world. And patients comply when you're able to explain them in easy and understandable manner. So if there's a diabetic patient and I say, please regulate your diet, change your lifestyle, and you need to work on your sugar intake, and that's all. On the other side, if I tell them what changes you need to make in their diet, if I tell them that the same 3 meals you need to take in 5 small meals so that you don't eat a lot at one point of time. Make sure that you don't take anything which is high in sugar. For example, direct sugar is not advisable. You can take one fruit, but make sure that you don't eat this fruit because these fruits have high level of sugar. And there is a risk for increasing your blood sugar level. So when you are explaining in these simple, doable manner, their understanding will automatically happen, and they will also start listening to you. So that's what the patient needs. But just saying that you need to bring in lifestyle changes. Now, what do we mean by lifestyle changes? I need to tell them. And when you explain them, they understand. And then at the end of the day, one message that I want to give to everyone. Please put the ball in the patient's court to decide how they want to lead their life. When you try to say, I'm your father, I am your parent, I will look after you, you need to comply with me. And when they don't comply and you get agitated and you say, I'm doing this for patient's welfare, I'm sorry. That's not the way things should work. They are adults. Your responsibility ends once you have explained them properly. See, you are not regulating your diet. You are not eating properly. Your blood sugar is not going down. Even if I keep increasing your medicine, that's not going to help you because your diet and your lifestyle needs to be changed. If you don't do this, this has irreversible impact on your vision, on your kidneys, on your other parts of the body, which you will not be able to reverse. And one such example is people develop diabetic foot. Now, when you explain all this and you say, no, it's your call whether you want to work on not yourself. If you have any questions, I'm ready to answer, explain to you, but you have to work on yourself. And that's all. That's where you draw a line. I think these are small things we need to remember when we are communicating. Again, not just with patients, their family member, colleagues, juniors, subordinates, and everybody else. Any questions about the videos that we have seen, or any point that we have missed that you wish to bring to everybody's awareness? Okay. If no questions, then we go further. So one request that I want to make here, I can see there are 15 of us, but we are only 12. Okay. Why I'm saying this, to keep your video on. That's a request I want to make. If you're not visible to me, I forget that you are there. Then I don't call you by name, and then I'm not able to engage you. Then at the end of the session, you will feel I was not engaged, I was not called, I was not asked. So if you're visible to me, I'll make sure that I speak to each one of you. But then you have to be visible to me. That's the only way I can engage with you. I hope you understand this. Thank you.
Ma'am, I have a problem with the connection actually.
Then I understand. I think you had made you can join using your mobile if you want. I'm okay with that.
Yes,
So if that's the situation, yeah. Yeah. Okay. So going further from here, I want to ask you a question. Any idea what percentage of your professional and personal success comes from your communication and interpersonal skills? Can you guess? Write in the chat box. What percentage of your personal and professional success comes from your communication and interpersonal skills? Okay. Dr. Soma says 80%. Okay. 90%. Okay. 68%. Anandita, very specific 68. Okay. Jana says 90. Vijayji says 60. Lavanya says 100%. Okay. Sambaji says 80%. Very, very close. Very, very close. Most of you are very, very close. There's a study by Harvard that says 85% of our personal and professional success comes from our communication and interpersonal skills. They actually studied the alumni of Harvard University. So they went searching for people, who were academically excellent, and they expected them to be very happy, very satisfied, very successful, and well placed in their life. To their surprise, it was not people with high IQ, but it was people with high EQ who were found to be EQ, that is emotional quotient, who were found to be more successful, more settled, happy, content. And people who have high EQ, those who have better understanding of their emotions and emotions of others, and those who know how to regulate their emotions, and they know how to behave with people to make them comfortable and make them connect with them, they are the ones who were very well placed in life and who enjoyed their life and they were very, very happy. Incidentally, we all think that for our work, we require the skills that are essential for doing your duty. But if you look at your college time, you had friends who were very, very good in their academics. And you had friends who were average in academics, but they had good, they knew how to connect with seniors, with juniors, with teachers, with everyone. See where they are and see who are academically very, very high. And look at the quality of life they're leading. Look at the enjoyment they're having in their life, because that's one factor it's not tangible, but that's very, very important and essential for all of us. So this study opens our mind to the idea that communication and interpersonal skills play a very, very huge role in our professional life. Even average clinicians with high EQ actually outperform clinicians who are with high IQ. That's the situation. And I'm sure you will agree with me. You can recollect a lot of your own colleagues who are around you. Even in your practice or in your workplace, if you have to, take any one of your family member to a senior colleague or a colleague of yours, if you have two doctors with almost same qualification and experience, whom do you prefer going to?
Experience.
And
person who can communicate and speak very well.
Absolutely. Two people with same qualification and same experience, but you see with whom you can comfortably talk, ask questions, clarify, ask your doubts, get more information. That's what people want from us. But incidentally, we think it's just the technical skill that's very important. So I think that shows us that the communication skills are very, very important for our personal success also. So by the way, in how many ways do we communicate? What are the different ways we communicate?
Two
that are
verbal and non-verbal.
Okay. What do non-verbal?
The body language, your facial expression,
Okay.
grooming, and even the outer grooming.
So,
and
okay. Anandita, so instead of two, I think we will make it three. One
Okay.
is language, that is verbal.
Verbal, vocal, and visual.
Yeah. Second is paralanguage. Paralanguage is how you deliver those words.
Yes.
Okay. And third is body language. Is it clear to everybody? So Guess what percentage of communication happens through words? Can you guess?
38.
No, let
38.
everybody try. Let everybody try. Anandita, maybe you know or you have read it. I want because people in healthcare, they don't get an opportunity to learn something like this in a very. What do others say? Anandita says 38% will communicate through words. Anandita, is that right?
Yes.
Okay. What do others say?
20 to 30% verbal, and more is the paralanguage and non-verbal.
Okay, great attempt. What do others say?
Ma'am, I think 50% through language, remaining through paralanguage.
80% through language, remaining to 20%. Paralanguage and body language is 20%. Okay, good attempt.
55% happens only through non-verbal communication.
Okay, 55% happens only through non-verbal communication. Okay, Dr. Sambaji says 40% is verbal. Mr. Vijayaraj says 50% is verbal and remaining 20 and 30%. Okay, very good attempt, I would say. Abhishek, what do you say? What is your guess?
I guess it's 40% should be language, and the remaining will be paralanguage and body language.
You know, you will be surprised to know, according to Dr. Albert Mehrabian, communication happens only 7% through words. 38% of the communication is through your tone of voice. And 55% is your body language. So when you are in this frame in front of me, even when you are not communicating, from your body language, I can quite precisely, estimate your engagement with me. Similarly, when we communicate with the patients, we don't say verbally anything foul. I'm sure we are very smart not to use any foul language. But our body language and when we speak, our tone of voice greatly communicate. They are able to get an idea how interested we are, how willing we are, how engaged we are. Nevertheless, words play a big role. Do you agree with me? They are important because we all communicate through words. So let's do a small activity on the importance of word and words. So what I want 4 volunteers from you. Raise your hand who wants to volunteer with me in this activity. Okay, Bijoy, Anu, Dr. Soma, and Anandita. Great. One more person. Anybody? Okay, Raminder, thank you. So I request 5 of you to keep your camera on, and to the rest, I request you to switch off your camera for a few minutes. Great, thank you. Sorry, Mr. Vijayaraj, do you want to participate in the activity? Okay, no, thank you. So imagine that we are planning to go for a picnic. We are discussing about the plan, and each one of us will speak about the plan, but how we will start our dialogue. I'm okay with the plan of going for picnic, but. So what comes normally after but?
Something negative, like
or some condition that fulfill this, then I will do, or there is something I can't do, something like this. So I will do the beginning, and then after me, Anandita will speak, and then one by one, each one of you will speak. So I'm making the beginning. See, I'm okay with the plan of picnic. But honestly, this Sunday, I'm very busy. I have, my friend who has come from abroad, so I will not be able to make it. Anandita.
I'll continue with the same line.
You will say, I'm okay with the plan of picnic, but.
Okay. I'm okay with the plan of picnic, but I'm little occupied this Sunday because Monday onwards my son's exam starts and he's in class 9, so leaving him behind doesn't make sense. So I'm sorry.
Okay. Yes, Raminder, what do you say?
I'm okay with the plan, but I would like to know by what time we'll be able to come back.
Okay. Yes, Dr. Bijoy.
This is the first time, so anyway, I will give it a try. I'm okay with the plan of picnic, but I'm worried actually whether I can make it this time because I have another pre-planned engagement. So I'm thinking whether I can cancel that, and I'm trying to come. I'm not sure about it. That's the problem. I can assure you within 2 days if you get some time.
Okay, thank you. Yes, Dr. Anu.
I'm okay with the plan, but I think can we postpone this plan to next week or some other because I have some prayer commitments.
Gai bhais pani mein. Eh? Yes, Dr. Suma.
I'm okay with the plan of picnic, but my diary is full of schedules. Is it okay to reschedule the picnic to sometime later?
Okay, so that means none of us is available and free and ready to go. Let's change the. And now this time, we will replace this word but with and. I will make the beginning so that all of you can add your point. So I'm okay with the plan of picnic and I'll make sure that I get food for all of you. Anandita.
I'm okay with the plan of picnic, and I'll ensure that my son studies and everything is complete beforehand. I mean, by Sunday I'll complete and I can go.
Wonderful. Yes, Raminder.
I'm okay with the plan, and I'll make sure that I finish my tasks beforehand only, so that my later part is not affected.
Okay, thank you so much. Yes, Dr. Bijoy.
I'm okay with the plan of picnic, and I have some pre-planned commitments. I'm trying to make that schedule ready, and within 2 days, I think I can make the plan perfect.
Wonderful. So you're okay to go with us. That's okay? Okay. Yes, Dr. Anu.
I'm okay with the plan. I'll try to postpone my work to the next week. So I'll be coming and I'll be spending some time with you all.
Wonderful. Excellent. Thank you so much. Yes, Dr. Soma.
I'm okay with the plan of picnic, and I'm planning to bring my Bluetooth speaker so that we can all enjoy some good music. Is that okay with all of you?
Oh, wonderful. So we'll have music. Wonderful. Thank you so much. I think so. The plan is on. Can I request everyone to come in? Please have your cameras on. So what is the observation? One person, 1 point, so that everybody gets a chance to speak. What did you observe?
The first point, the first part where it was but. Nobody wanted to give up. They all gave an excuse, but it should have been like this. I wish I.
So that means
like,
everybody.
Nobody will say, okay, let me forget.
So what was a hurdle?
Join your.
What was a hurdle?
In the second part,
not
it
second
was
one, not second. First one.
Okay, and we'll do that. We will enjoy. Nobody said, okay, let's go and happy.
Thank you.
Hello.
Dr. Abhishek, what is your observation?
I think everybody is scared of the proverbial but whenever there is there in the sentence. So, rightfully so, because it has these bad connotations associated whenever we use but in a sentence. So, I think, yes, when somebody uses it, I think we already are preparing ourselves that it's not going to be something favorable.
Absolutely. Absolutely. So that means whenever but comes, we know this thing is not going to happen. There will be there will be something that will stop us. And the moment I replace this word but with and, did you see the change in the energy? Did you see the change in the action? I'm sure you must be observing this a lot of time when you are working with your team. There are people in the team, it could be ourselves also, who use more often but than and. We'll come up with the remotest, reason to say no. And we create hurdles. So first of all, check your communication. Are you using more but than and? If that's the way, then you need to work on yourself, because that means I'm creating more hurdle for people and my team. That's one thing. And second thing is, what are the common things that we say, not this and but, that can be considered as not really welcomed way of talking? Can you think of something that you say to your juniors or seniors or subordinates at home with your family members? Patients.
It's like Abhi nahi yaar, don't talk to me now, talk to me later, okay? So that gives a very a negative feeling, when somebody wants to speak to you and then you reply back in a very negative way that abhi nahi yaar. Don't give importance to that person.
Absolutely.
Yes.
How much, ma'am, how much we think that we can be very busy. Actually, we can always find out time for something. We are actually not busy. We can be always easy.
Yeah, but we give that excuse and we try to escape that situation. Yes, I agree. Yes, Dr. Abhishek, what is your input on this?
I feel like we should, whenever somebody comes with some exciting idea or thought, we should try not to rain on that parade. And let them have that moment.
Also, a lot of time we have not even heard them fully.
Right.
We have not even allowed them to express or explain what the idea is. No, this can't happen. How can this happen here? This is not possible. And more often than not, if you will just think and say, probably instead of no, you will say, okay, let me understand. Maybe I'm not getting the complete picture. I first need to understand what you are trying to say. But then instant is no, it's not possible. It cannot happen. This is not possible here. And especially we are very resistant to change, to new ideas. And that's where people get blocked. Yes, Dr. Soma, you wish to add something. Go ahead, please.
When I work with my students, so the moment they try attempt doing something, the moment I say it won't work, they will stop doing that. So I reframed the sentence. I used to say like, that's a good way of doing things, but sorry, I usually I don't use the word but most of the times. So what I say is, that's a good way of doing things. I have a different way of doing things. Would you like to see that? So they will be more curious to learn, and then the communication flows further down the lane in a better way.
Wonderful. I think so. But comes as a no, stop, not useful. You're not making sense. So can you recollect something that your seniors said you, something when you were young and you were like still beginning your career, that you did not like coming from your senior? Can you recollect anything? Or juniors who are there, who are young, like you are with us, anything that your seniors say that you do not like? You don't have to name anybody, but just say that I see this coming. Dr. Abhishek, you wish to add something?
During my internship, I was repeatedly told that my suturing skills were very bad.
Absolutely.
And ironically, surgery was my first posting in internship. So it's like, where am I supposed to pick it up? I don't know. So yeah, but that was brutal.
So how discouraging that can be to somebody who wants to actually take up surgery as a postgraduate specialization, and then somebody said even your basic suturing skills are not okay. Maybe yes, they are not okay, because when you are beginning your career, there will always be some errors in this beginning, and then you refine on those skills. But the way you are snubbed, it actually comes as an insult. A lot of time we get to hear from seniors. I don't know now if it is practice or not. Tu kar le, tu chala ja, tu ye kyun nahi karti, tu idhar kyun nahi aata, tu sunta nahi hai, tu and tum. You get to hear this now also, juniors, youngsters? I'm sure long ago this was a practice, I remember. I don't know now if that's a practice or not. How many of you like that idea of being called tu and tum?
Not
It depends
never,
upon.
never.
Yeah.
It's not good.
It's not liked. But although you could be doing it thinking that, oh, I'm senior, so this is like a child to me, son to me, or a brother to me. Once you have that rapport, maybe nobody will mind if you call them tu kar le, tu chala ja, tu aaja. But when you are not even familiar with each other, and if you use this language, today, even your children will not like you to use this word for them. I remember my kids when they were young, if any time by mistake I said, Jasmine, tu kar le, ye kyun nahi karti? Mama, tu karke kaise baat kar rahe ho? I mean, they will immediately point out. I'm sure, I mean, that comes as a blow. So seniors, anything that you say that you think is not appropriate? Can you think of anything that you say?
What we say?
मुश्किल क्वेश्चन पूछ लिया, दिखाई नहीं दे रहा, तुझे समझ नहीं आ रहा, तेरा दिमाग नहीं है, अरे इसके बस का नहीं है, इसको मत बोलो, ये नहीं कर सकता, इसको समझ ही नहीं आ रही बात, ये क्या करे? Haven't you heard these words? So language plays a very big role. Think before you speak. It can actually do more damage than any good. So we have to be very careful with words. And especially with patients, what happens with patients when you explain them? Let's do an activity. Let me show you a slide. I want you to read that slide, and then we have a discussion around it. So this we have discussed. If we use disrespectful language, or we are rude, authoritative, and uncourteous with people, or we snub them. तुम इलाज करवाने आए हो, मेरी knowledge check करने आए हो. I'm sure you must have heard these words. And sometimes when we don't use basic courtesies. Okay, let me show you this slide that I want to show you. Read the following paragraph. क्या समझ आया?
It went so fast, it was difficult to grasp.
You know, studies suggest 50% of the patients and their family members do not understand much when you explain them about their disease condition, treatment, procedures, prognosis. Because we use lot of jargon. We use words that we think patient will understand. They don't understand, but they dare not ask and tell that I don't understand what you explained. Tell me how many times your patients have told you कि डॉक्टर साहब जो आपने बताया मुझे कुछ समझ नहीं आया. Please एक बारी दोबारा बताइए. Any time has any patient told you this? Very rarely. Unless the patient is very comfortable with you, they will hesitate admitting that I have not understood, because they will consider if I say I have not understood, that means I am idiot, or I am with low IQ, or I am unintelligent, or I am less educated. So they don't want to take that label. So therefore, they will never come up to you and say, I have not understood.
Madam, patient will not say, but their body language may say.
Absolutely. If we are mindful, if we are observing, if you will look at their face, and if they give blank expression, you will get an idea the patient is not understanding. If they are confused, you will be able to make out, but only if you are vigilant and observing their body language. A lot of time, we don't care much to observe their body language. Then what happens? We never get to. And also we are in hurry, or we are occupied, or we have another task at hand. And that's where We think we have communicated, but actually the other party has not understood much. And what I'm sharing with you, a number of studies that show that they don't understand, but they don't say, because they feel if they will say, either they will be. And also, suppose if your patient said, Doctor, मुझे एक बारी दोबारा बता दीजिए, समझ नहीं आया. You will try once again. But what will happen to your tone of voice and your, overall body language? And unfortunately, if the patient said, Doctor, अभी भी समझ नहीं आया. सबसे पहले आप अपने कान जांच कराइए. मुझे लगता है आपके कानों में. Dr. Vijay, समझ आई मेरी बात? Dr. Vijay? Oh, so I'm just trying to give the situation, and I'm sure in private sector we don't talk like this. But if you will go to the government hospital, very often you get to hear this. भैया इतने सारे पेशेंट हैं बाहर, सिर्फ तुम्हें ही नहीं देखना मुझे. बाहर देखो जाके 200 पेशेंट बैठा हुआ है, एक एक के साथ 10 मिनट लगाऊंगा तो कैसे बात करेंगे? That's how we snub them. And that's where the communication fails. So that's about verbal communication. Now let's see some examples of written communication. Let me share the screen once again to show you. Written communication example. So this is one sample of the progress notes of one of the patient in one of the government hospital. This is another one. So what is missing in this, by the way? Again, in one of the, again, government hospital. What is missing?
It should have been written in bold letters, no, ma'am?
Everything can't be written in bold letter, but it should be readable, comprehensible. Yeah.
Patient details are missing.
Yes. Patient's details are completely missing. Whose Lama summary it is. Let's see the next one.
Not there.
Yeah, you will see a lot of things missing. This is by one of the private practitioners. I have actually hidden the name and everything, but just have a look at that. This is a recent one, not very old, last year. So you can see our notes. What are the common errors that you get to notice or you have seen? What are the common errors you have noticed? Otherwise, not only in this document, but in your work area, what errors do you often get to notice in people's written work? Are you writing in the chat box? Yes, illegible handwriting. That's one of the commonest problem. You can't read anything. You can't comprehend. Absolutely. What else? All the instructions are clubbed together. Yes, again, that can be a problem. No date. Yes, no date, no time. Signatures are missing. Yes, doctor's name may be missing. We just write, we just write our initials. No margins. Yes, that's also common. Yeah. Failure to sign, not writing date and time. Absolutely.
It can lead to some medication errors, mismatch or something.
Lot of errors. I completely agree with you. Registration number. Yes. No SNDC
So
sign.
congested.
Yeah, it may be very congested. So common errors that you will get to see is, like you said, illegible handwriting. Very often that will be the biggest challenge. Also, you will see people use abbreviations that are not standardized. Even if they are standardized abbreviation, please remember, if this document is for the patient, if they are not familiar with that abbreviation, they will not understand. SOS, BD, TDS, OD, HS, they do not know. I'm sure a lot of time you may have seen people taking medicine when you have written SOS because they think I have to take this medicine. So they will take it. Again, overwriting is another problem. They will strike something and they will write something over it. You don't know what it is. I think even in this you can see SOS 5 to 6 per month. Now this is 5 to 6 per month. What it is? Now, if you see even the sample which is seen visible on your screen, now this 5 to 6 per month is for what? Is it for the medicine, or is it for the right side thing? I don't know. You can tell me better. Also, very common, done but not documented. So I remember one of the gynec was sharing her experience with me that a patient came to the general emergency. She was in labor pain. The resident who was on duty, she said magnesium sulfate and transferred the patient to the gynae, emergency. So the staff or the resident gave magnesium sulfate and the patient was moved to the gynae emergency. But incidentally, nobody mentioned that this medicine has already been given to the patient. Now the patient is moved. The nurse or the resident who received in the emergency, they thought that these are the instructions. They gave the second dose of magnesium sulfate. You know very well what happens if the patient receives double dose of magnesium sulfate. Patient went into respiratory distress, was moved to the ICU. Ultimately, with a lot of struggle, they could only save the mother and lost the child. So many a times you must have seen that patient, something is done, but if you don't write, it is taken as not done. Somebody might redo it and can have fatalistic effect. Another common error you will see, documented but not done. Somebody goes to give medicine, the patient is not on bed, maybe the patient has gone for some investigation or to the toilet or somewhere, and the staff comes back, and meanwhile she signs in the injection notes or the medicine notes and says given, but the medicine actually was not given to the patient. So you don't know whether the patient has received the medicine or not because it is already signed. Very often even this is seen as a problem. Then document not signed, dated and timed. This is very common. Now even in this, if you see, the signature is more like initial. So I was asking these residents when I was taking a session, why do you sign like this? So they said nobody should get to know who has written this document. Now, of course, in government setup, you have to actually put a stamp under your signature. Otherwise, the patient will not receive the further treatment. But when you're doing like this, you may be thinking that nobody can identify who has written this, prescription or the notes. It's not difficult to find out. You think it's difficult? It is not difficult to find out. So we are just fooling ourselves when we say nobody should get to know who has written these notes. It's a very easy task to find out who has written this. Another common problem is language barrier, especially if you are not familiar. I mean, most of the written work is done in English. And if that's not the language that we speak or write, there will be a big challenge. Not only this, in a lot of states, I have seen they write in their local language. Now, I used to go for assessment for NQAS, and a lot of time in number of states, not only the staff speaks the language, local language, but also their notes are in their local language. So if you are a doctor or a nurse who does not know that language, you will not be able to make use of that document. So language can become a barrier. And then, of course, one of the commonest problem is poor writing skills. Tell me, how many of you actually got a formal training in writing your notes? Raise your hands. Those who actually received formal training from your professors or from your college to write your notes. I don't think. What you learned was either observing your seniors or what you thought was appropriate. But that there are standardized formats to write patients' case notes or prescription or case history. And when we don't know how to write, then we fail to write. I don't know how many nurses are confident to write nurses' notes. How many of them actually write proper notes pertaining to each patient depending upon their observation or their nursing plan or whatever they have done in patient care. Mostly it is copy-pasted. I hope you agree with me. In how many hospitals do we have electronic health record system? Do we have in all? Almost all hospitals?
Every family has.
Holy family. I think in most of the corporate hospitals we have this. Am I right? Okay.
Most
So
of the
what-
hospitals have been migrated now from
Yeah,
normal to
yeah. But what challenge are you experiencing on that front? Although it was introduced with the idea that at least the legibility and the comprehensibility will become better, but what challenge are you facing with that?
Many times it is being reported that is taking the nurses more away from the patient and they spend a lot of time on documentation.
Absolutely. It's not just nurses, even doctors complain this, that we have become more clerks than doctors. I get to hear this when I talk to them. They say we are mostly doing the entry. And honestly, I mean, I'm sure many of you are, and I think Dr. Vijay, you are also NCOAS assessor, if I'm not wrong.
Yes, ma'am.
So when we go for assessment, lot of documents are ready to read. But when you ask them, what have you written? What have you done? There's a huge disparity between what is being written and what is being practiced. So I'm sure in a lot of hospitals, that's what happened. Lot of copy pasting is done. Picked up from one place, paste it here. Even nurses note, doctors note, copy paste it. So what happened? You are not actually writing notes about the patient, you're just completing the written responsibility. So these are the common challenges you experience when it comes to written communication. So briefly, I've touched on the words, language, and written part. Moving to the second part, and that is paralanguage. As I said, your paralanguage is almost 38% of your communication. By the way, what all comes in paralanguage? What all comes in paralanguage?
Tone of your voice.
Okay, tone of your voice.
The facial expression?
That will go in body language.
Ma'am, the
Volume of
facial expression.
facial expressions will go in body language. We'll talk
Okay.
about that in body
Okay.
language. Yeah.
The
So
volume,
volume, yes, volume. Very true.
Posture.
Posture. Posture is the body language.
Clarity
Eye
of
contact. Eye contact.
Eye contact is also part of body language. We'll be discussing at length. We'll be talking.
Voice modulation, ma'am.
Voice modulation, volume, speed of talking,
speed.
tone of voice. Somebody comes in and I say aye. Somebody comes in and I say aye. I didn't change the word, but I think the whole communication completely changed. Could you see a tinge of arrogance in my tone?
Yes.
Rudeness,
Yes.
unwelcoming attitude,
yeah.
not interested. See, just tone of voice could change the meaning. I use the same word. Pause. रोको मत जाने दो. रोको मत जाने दो. The whole meaning completely changed. So paralanguage is all about your tone of voice, volume, speed of talking. So let's read one sentence and see how the whole meaning changes when you put a little emphasis on a word, differently. Now read each sentence with little emphasis on the word that is underlined. And you will see how the meaning changes every time. Read it to yourself, yeah.
Each sentence shows which word you are emphasizing.
And the meaning changes, intention changes,
Yeah.
Yes.
focus changes. Absolutely. So what do you think when we talk about tone of voice? What do you think, what is the inappropriate tone of voice?
Madam, it is not what we say, it is how we say.
Absolutely. I agree. I completely agree with you. The way you talk has an impact on the intent.
Appropriate tone means if the person gets the real message.
So, okay, let's talk in practical terms. What is not okay in the tone of voice? What tone of voice should we avoid? Can somebody tell me? 1.1%?
Irritated in the speech.
Okay, irritated. Yes, people get to know that you're not interested. Yes, Dr. Abhishek, you have shown your hand. Go ahead, please.
Any kind of sarcasm.
Sarcasm, absolutely not desirable. Absolutely. What else?
Teasing tone.
Sorry?
Teasing.
Teasing, yeah. Sarcasm and teasing. Absolutely right.
Harsh
Loud,
tone.
harsh and rude. Absolutely. Rude and authoritative tone is not welcome. That's
Loud.
loud. Loud. If you are shouting, there's a huge risk that you are calling for a problem. I will give you an example here after this. So let's first have a look at what is inappropriate. If you sound unfriendly, to your patients or their family member, they feel uncomfortable. They feel that you are not welcoming. Anywhere, if you sound disinterested or unconcerned, patient family has come complaining to you that the patient is complaining of pain. And then you say, okay, somebody will come and see you. And your expression and your body language and your tone of voice says that, okay, it's not a big deal. Why are you making an issue out of it? They immediately feel that you are unconcerned. Anywhere, if you sound inconfident, they ask a question, and if your answer is not confident and not clear, they lose confidence in you. Also, if you sound rude and authoritative, absolutely, they can sense it in your tone of voice. And also, if you are aggressive. So, not only selection of words, but your tone of voice can communicate aggression, and all this is inappropriate. Of course, in patient handling, with our team members, with people with whom we work, we have to be professional, but at the same time, we have to sound friendly with. Whenever there's a discussion, there's a point, there's a question answer, there's a clarification, we have to respond to it with responsibility in a professional manner. Confidence. From where will the confidence come?
When you know what you're talking about.
Yes.
What you have
Knowledge.
Information, yeah.
Absolutely. Knowledge and practice. If you know what you're talking about, definitely you will sound confident to the patient. We have to be soft and polite, but at the same time, we should be audible also, and then assertive. We'll talk about assertion at length, but all in all, let me tell you, inappropriate tone of voice can trigger extreme reactions, which can lead to violence, especially in public dealing. If you sound little aggressive, trust me, everybody will stand against you, and they will, kind of start blaming you for your misbehavior. So in a public place, if with your patient, you need to be soft, polite, professional, and also confident in what you are saying. So when we talk about the voice modulation, you need to be soft, but you should be audible at the same time. If you're not audible, your patient will not understand much. They may not come back to you and ask you that I could not hear what you said. So one is you will lose the message. If it goes into air, it has not reached the target. And also it can lead to confusion and errors in patient care. A lot of time when we talk to the patient and when we are doing the same thing repeatedly, unknowingly our speed also goes up. But we don't realize the word we are using, the vocabulary that we are using in our day-to-day functioning, that may be completely unfamiliar to the patient and their family. If they don't understand, and if your speed of talking is, faster than their understanding speed, chances are that they will not understand. And if they don't understand, there's a possibility there can be an error. Lot of time when you explain when you're talking about the discharge slip and you are, explaining to your patient about the discharge notes, what medicine they need to take, what precaution they need to take, when they need to come back, and when they need to report in case of emergency, I request you to ask your patient, have you understood? Patient will say yes. Ask them to repeat it for you. They will not be able to repeat more than 50 to 60% of what you have mentioned, because they don't understand, but they will not come out and say that I have not understood. And a lot of time, what you said and what they understood could be very different. That itself can cause a lot of confusion. So this is in nutshell about paralanguage. The third is body language. Now, talking about body language, what do you see in this picture?
Very angry.
Okay. What else?
Screaming, shouting.
Screaming, shouting, angry. We didn't hear anything, but you could really very accurately guess, because 55% of the communication happens through words. Yeah, our body language, and most important of that is our facial expression. Facial expressions, eye contact, gestures, posture, touch, space, all these are part of body language. And they communicate hugely. Even if you don't understand the language of the other person, you can make out from their body language how connecting they are with you. Especially in a public place, the way we stand, the way we sit, the way we conduct ourselves, they observe us. And they kind of, assume from our body language that this is what we want to communicate to them. Let's do a small activity here. So I'm going to take you to your childhood. You will have to, do some actions with me. Ready? So have your hands free, everybody, and have your camera on. Great. Thank you. So I can't see, Semil, your camera on. Is there some challenge on your end? So there's a poem.
I will be unable because I'm having a mobile. So you will have to excuse me.
Sir, next time, please join using your PC because you will enjoy. Second, if you are using mobile, put it somewhere. Can you put it somewhere?
Difficult. Maybe you excuse me this time.
किसी को बोलो कि आपका कैमरा सिर्फ 2 मिनट के लिए पकड़ लें ताकि आप एंजॉय कर पाए जो मैं करवाने वाली हूँ.
I'm really sorry, I'm alone.
Okay.
Please excuse me.
It's okay. I understand. That's okay. Okay. So I'm taking you to your childhood and you have to do actions with me. I'm sure you must have heard this poem many a times in your childhood. If you're happy and you know, touch your nose. Okay? Ready? Everyone ready? So you'll have to first, we'll do one practice and then we'll do it fast. If you're happy and you know, touch your ear. मेरे साथ साथ जल्दी जल्दी करना है. If you're happy and you know, touch your nose. If you're happy and you know, touch your ear. How many of you were about to touch your chin? Aparna, Raminder, Jana, Anu, you were also there? Yes. Because you were listening to me, but you were actually observing me. So this I demonstrated to you to help you understand when you are agitated, you're angry, you're unwelcoming, your patient or to your junior or to your team member. If you're disinterested, even verbally when you don't say anything, they can make out from your expressions. So like we say, face is the mirror of your mind. Honestly, yes, because people look at us from our facial expression, they can make out how interested we are in talking to them or engaging with them. So in this slide, you can see 9 expressions. Tell me, which is the commonest expression we have when we are interacting with the patients or their family members? And let's be honest. Number 1, 2, 3, 4, 5, 6, 7, 8, 9. Which one? Number
5.
5.
5.
5.
5.
And what is in 5?
General.
No expression, no general.
No expression, neutral.
No expression.
Neutral.
No, it's
No
not
expression
even
at all.
Okay, if it was neutral, will you be happy getting treated by a doctor with this facial expression?
No.
No. Will you be happy being handled by a nurse with this expression?
No.
Number 1.
Then why do we keep this expression? Why do we keep this expression?
Because whatever we are thinking inside, automatically it shows on our face.
That's also true. But can anybody guess? Why do we keep this expression?
Neutral one.
This is not neutral. This is no expression at all.
Because most of the time, we are not listening to them.
No, even when we are listening, we keep this expression, even if we are listening. There's a secret.
We do
We
not
don't
want,
want
we do not want others to know what is going on inside us.
You're already showing that I'm not interested in listening to you. We keep this expression because we don't want to build connection with the patient. We don't want the patient to come closer. So we want to keep them at a hand's distance. Please stay away. You know, if you will smile and talk, patient will try to come closer. They will ask you questions. They will ask you information. They will ask you for help. You will have to answer them. You will have to explain them. You will have to provide that help. Just to avoid that, we have a straight face with no expression so that the patient can feel the distance. And we want to remind the patient, please do not cross this line. Now, if we don't like to be treated by a doctor or a nurse with this expression, imagine what your patients must be feeling. So it's very important to be mindful of the facial expressions. So anytime when you have expressions like this, trust me, your patient is never going to be happy. If the patient tries for secondary gains, you can assert. I'm not saying that you do what the patient wants to do. What you think is not appropriate, you should know how to assert and say no. You know, facial expressions like anger, irritability, unhappiness, attitude, they are visible on our face. People can make out. When you go to your senior's office, you can make out from their facial expression whether they will listen to you or not, whether they will agree to you or not. Similarly, your patients can make out from your facial expression whether you will be helpful or not. Let's do a small quiz. Can we read the expressions? Do we know how to read people's expression? I'm taking you to a quiz. Okay, so this is the expression, and options are, this face is expressing embarrassment, fear, sadness, surprise. Write in the chat box. What do you think? What is this expression? Okay, embarrassed, fear, embarrassment, fear, embarrassment, fear. So there are more fear answers. So I'm going by majority. Let's see if we are right or wrong. Correct. Okay. Now, let's go to the next question. This face is expressing flirtatiousness, interest, happiness, politeness. Happiness. Okay, happy, happiness, interest. Okay.
I think politeness.
Okay, so I'll go for happiness because most of the people are trying to say happiness. Let's go by majority. Happiness. Okay, let's see. Correct. Wonderful. So we are going good. Third one. What does this space say? Sadness, pain, anger, disgust.
Anger.
Anger. Okay. Most of the people say it looks anger. Okay. Very right. So we are going great. What about this one? This face is expressing embarrassment, sadness, amusement, shame. What do you say? Sorry?
Amusement.
Amusement. Okay. More answers of amusement. Okay. There we go.
Shameful amusement.
Embarrassment. So I hope this gives you an idea that really we do not know much And we really need to know deeply, because patient's expression communicate a lot. But that we will only get to read when we will make eye contact. How many of you have experienced something like this, where you are standing in front of a person, but that person is busy doing either a phone call or some writing work or communicating with somebody, but is not paying attention to you?
Yes, many times.
We have all faced this. We have all seen this. So it's very important to make eye contact. Why is it important, by the way, to make eye contact? Why is
It
it
says
important?
that you are attention. You are
That
showing
means you are
attention
paying
towards.
attention. Absolutely. What else?
You can understand the feeling, or rather the communication, the non-verbal communication part.
Okay, when you are looking at the person, you are able to read the non-verbal. Yes, Dr. Abhishek, go ahead.
It helps in establishing connection.
Absolutely. When you make eye contact, it helps establishing eye contact. I completely agree with you. You can actually communicate compassion, care, concern through eye contact. But ask yourself, how many times do you really make eye contact with the person? Honestly, if you look at the person for a couple of seconds, you can not only connect with the person, you can connect with the soul if you are able to look deeply into the person's eye. So the protocol of making eye contact is look at the person for 2 to 3 seconds and then shift your focus. Please do not look beyond that. Staring becomes more like challenging or refuting the person, and never look at the person from head to toe. That's not a good idea. In a personal relationship, you can look at the eyes and below the eyes. In a professional relationship, always look at the eyes and above the eyes. Also, when you are talking to your seniors, where you are little uncomfortable or you are not very sure of yourself, it's always good to look at the eyes and little above the eyes, so you will feel less scared to communicate what you are saying. But with patients and their family member, when you're talking, making eye contact is very important, but we have to keep shifting the focus, especially where you are using electronic health records and you are entering simultaneously. So you have an iPad in front of you, or a PC or a computer, and you have to simultaneously keep adding the information. It's very important to hold in between and then look at the person, especially when the person is talking about something very sensitive or something that is upsetting for the patient, for example death or disease or some mishappening. That's where you need to pause your writing and typing, and then listen to the patient, and then maybe you continue. But that amount of eye contact is very, very important, even when you are simultaneously entering the information on the computer. Now, coming to the posture. In this picture, there are two postures, A and B. Which is okay? A or B?
B.
B.
B is okay?
Both are not okay.
Yes, both are not okay. In A, the person appears very casual, callous. In B, the person appears very
confident,
closed.
Closed communication.
Yes, closed.
So if somebody is listening to you with this posture, B, you will have a feeling that this person is not going to be
Not
listening. So when you want to communicate that, yes, I'm listening to you and I'm interested in what you're saying, it's important to lean forward and then nod in between, communicating that, yes, I'm listening, I'm understanding, I'm agreeing with you. Okay, touch. So what challenge do we experience when it comes to touching the patient? Do we experience any challenge when we have to touch the patient?
Touch appropriately.
Okay, we have to keep in mind that we have to touch appropriately. I agree completely. What else?
Touch is an important part of communication, provided it is being used in a wherever appropriate.
That's very important. In healthcare, touch is unavoidable. You have to touch the patient if you have to examine or to do any procedure. But the problem is, on the other side, the patient actually may feel uncomfortable when the patient is being touched. So when you are touching the patient, it's very important to let the patient know that I'm going to touch you, especially if you are a male therapist and a female patient, or vice versa. It's very important to let the patient know that I'm going to touch. And if you can sense that uncomfortableness in the patient's body language or overall expression, you have to make sure that the patient first becomes comfortable and then you allow the patient, then you touch the patient. I remember I was taking a session in one of the hospitals, and I was shared this experience that ECG technician, he did ECG for a female patient. Now of course we have female and male ECG technician, but there was a time when we had only male ECG technician, and this patient was she underwent ECG, and then she came out and then she told her husband that so and so person did my ECG. And this man, husband of that lady, went inside and he literally caught hold of the technician, that how dare you touch my wife. So it's very important. There was a time we did this and nobody really cared and bothered, but now I think it's very important to remember that we have to be very, very careful. Of course, we know that touching the patient on the shoulder or on the head or on the forearm is a way to communicate compassion, care, concern, empathy. But we have to be careful because touch can be misunderstood. Unless you have wonderful rapport with the patient or their family member and they trust you, it's always good not to touch unnecessarily. And every time you touch, please signpost. I need to check your throat. I need to check your back. I need to check a part of body. And before you touch, it's better to seek permission. Although you may say that there's an implied consent, but please remember, implied consent we know, patient does not know. So it may sound like a rhetorical question when you say, is it okay if I do this? 99.99% patient will say yes. But you are giving an opportunity to the patient to say no in case if they are not. Lot of time we have seen female patients say, no, I want to be examined by a female doctor and not the male doctor. We have to respect their believe or their expectation, and we have to see how we can win their confidence or have somebody from their family talk to them, and if it's possible, have another clinician examine the patient or another nurse, maybe female nurse, to do the same procedure. So it's important to actually inform and seek permission before we touch the patient. Next is hand movement. So what kind of hand movements do you think can be very inappropriate? Can you show me some hands? And show me. Dr. Soma, yes. Which one? Which one? When you say chup ho jao, bas karo, ho gaya, bahut ho gaya, zyada mat bolo. So see, hand movements, yes, we all use hands, but we need to be careful when we are using hands. Especially, let's not show the kind of hand that can be inappropriate. I remember in one hospital, the argument or the fight was when the staff said, "आप यहाँ से बाहर चलिए." She showed finger. "आप बाहर चलिए. आप उधर जाइए. यहाँ क्यों खड़े हैं?" And then the attendant was very unhappy that this is not the way you can talk. Also, we have to remember not to point to the disease part of the body. That's very important. A lot of time we think that we can show that part of this part. I think patient feel very uncomfortable. So that's not something that's desirable. Hand movements like this. So what do? That's not my problem. That's your call. Or like just now, Dr. Soma was showing that hand. Keep quiet. Don't speak much. So again, that can upset the person. So we have to be more careful about using our hands. We all use hands, but we have to be more careful and mindful of our hand movement. Okay, whom does this person look like? Whom does this person look like? Trust is built on the way we appear. Although, I mean, for me also, if you ask me, for years, I never realized or never thought that it's very important to appear professional and, to look in that form. But I realized actually I got a video recording done for my 3 days program in one of the hospital. I thought I'll be using those clippings for my, for my showcasing my work. But the way I was looking in that total picture, I felt, oh, I can't even put this on a social media. Please remember, patients and their family members are constantly observing us. So if we are not dressed up formally, professionally, they sense that we are taking it in a very casual way. We are not, we are not acting professional. So especially with the residents and with the, with the younger generation, I a lot of times see them wearing high heels. You can't be wearing high heels and walking in the hospital because whole day you have to run up and down. I also see people wearing very bright colors. So especially colors like yellow, red, blue, if you are wearing such colors, patients feel that we are not in sync with them or their state of health. I'm not saying that we have to start using only black and white, but then we have to remember that it's a healthcare setup and patients are suffering. So they want us to, in a way, express empathy with them, even when the way we dress up. I think 3 questions. Of course, you all are very senior, so I don't think this applies to you. But then definitely when you are teaching this to your, juniors or youngsters and in your induction program, this is something you will have to actually very clearly spell out and tell them that please make sure that you are dressed up appropriately, professionally. I think 3 questions, if they ask themselves, they will get an idea whether they are dressed up properly or not. First thing is, does this clothing fit me properly? A lot of time we have seen people wearing too tight or too loose clothes or too short clothes. I'm sure you must have also seen this. Sometimes they are wearing very loose sweater or baggies and sort of thing, or very tight or short clothes. That's something they need to ask. And then second question is, are these clothes comfortable? We have to remember, we have to run up and down, we have to bend down, we have to lift things, we have to handle so many things. So the clothing have to be comfortable. And the third question they need to ask is, am I dressed up appropriately for my position and responsibility? So I remember I was taking a session, I had gone to take a session at Delhi Judicial Academy. I take sessions for the judges who are newly, appointed judges in their induction program. So prior to me, a very senior judge, retired judge, had come to take a session on dressing. And she was talking about, to the judges that you should wear formal clothes, you should wear sari. And those young judges who had just been recruited for the SDM position, they were literally fighting tooth and nail with the senior judge that why are we asked to dress up like this? Why are we asked to dress up in a very, very formal manner? I think one thing that I want to say here, people, trust us from the way we appear. If you don't look like a doctor, if you don't look like a nurse, if you don't look like a professional, people will not treat you. Especially when I talk to young doctors and nurses, when I take sessions for the residents at Maulana Azad Medical College, I tell them, a lot of time those interns tell me, man, they call us sister. I said, if you don't look like a doctor, they will assume female means sister. And sometimes boys say, young doctors, male doctors says, they call us technician. If you're not dressed up properly, if your clothing are not okay, if your apron is not okay, and if you're looking like technician, they will consider you technician. So if you want to be, treated respectfully, you need to dress up in a manner that they can make out that you are a professional. And that's very important to remember. So this is about dressing. Please make sure when you are taking this session for your audience, talk about dressing. That's very, very important. The next thing that we can talk about is the personal space and privacy. So we all like to be safe. We don't want anybody to come closer. So patients also feel uncomfortable when we go close to them. We have to go when we are examining, when we are, talking to them, interacting. So somebody's mic is on. Can you please mute your device? So that invisible boundary actually becomes apparent when we go closer to them. So how much of distance do you think is appropriate to maintain with the patient? At least when we are not examining. Of course, when we are examining, we have to go closer.
1 hand distance?
Sorry, how much?
1 hand?
Yeah, 1 hand. So that comes to more or less 2.5 feet distance. So we have to maintain that distance so that they feel comfortable and feel safe with us. At the same time, in case if we need to go closer and check the patient, for example, if you need to check the throat or ear or eye, it's always again good to tell them, I need to check your eyes. So that means I am going to come closer to you. Second is it okay with you? So when you seek permission, they have an option to say yes and no, and that's good enough. If you're able to, give them a chance to say yes and no, they will feel okay that I have been given that option. Next is about respecting their privacy and confidentiality. We examine the patient a lot of time, not even properly covered. I'm sure you must have witnessed it hundreds of times. Of course, now that does not happen in corporate setup, but in government setup, even now I've seen this happening. So we need to really be very, very careful about it. I would just say one thing, and that will give you an answer. Put yourself in that position and ask yourself, will you be comfortable if you were treated like this? That's all. That's all. If we remember this, I don't think we will ever, compromise patients' privacy or confidentiality. There's another picture sent by one of my participant of the program. Imagine the way the baby has been put on the, table, and sorry to say, but these are health minister and other officials, visiting this patient. The way this patient has been put on the table, and everybody is looking as it's a specimen for something. We have to be, though our patients are not very demanding on this front, especially in the government sector, but we have to remember it's not a very comfortable thing. Last thing that I want to talk about is valuing their time. That's also part of non-verbal communication. We make them wait, we don't apologize, we don't give them reason, and a lot of time after making them wait, we say, sorry, it will not be possible today. You have to come tomorrow. There was a time they were okay with that. But today you must have seen patients are very, very upset if you make them wait like this. They feel very bad if you turn them around. You say, sorry, the doctor has not come, or the doctor is busy in the OT. They'll say, why could you inform me earlier? You have wasted my visit. I've lost my one day. In government setup, we know the kind of patients we receive. They are usually from a lower income group. They are mostly daily wages. They lose their one day income. And it's not the one person who comes. Sometimes they have their family member with them. Not sometimes, always. They will have 1 or 2 attendants with them. So it's not one person losing the day. It is 3 people losing the day. Lot of now effort is being made to reduce the waiting time and reduce the number of visits. I think that should be on our priority. The whole idea of this session is, please remember, we have to display respect and care through verbal and non-verbal communication at every point of time. There are 5 skills that I want to talk about, but not today. We'll be talking in the next session, because I want to again do that through activities that we will remember better. And then this session actually will be complete. So this session is not complete. I want to talk about some skills that we all need to keep in our pocket while being in the healthcare. And if you have them with you, you are good to go. But this brings us to the end of today's session. Let me know what questions you have about whatever we have discussed. So 2 tasks I'm going to, give to the group between you to decide. One is, I would want one of you to summarize the session, what we have learned. So turn by turn, one person will summarize the session, and the second one will have at least 2 questions to ask. Between you, you can decide, but make sure that every time, because that will keep you engaged, active, and participating.
I'll summarize.
Oh, wonderful. Thank you, Sibyl. Go ahead. And then Anandita has probably raised her hand. She wants to say.
Yes. Yes.
After Simil.
Okay, we have started with talking about emotional quotient, EQ. EQ is more important than Q, because the success mainly depends more than.
Your camera is, your camera should be placed in a manner so that we can see your beautiful face.
The success is more dependent on EQ than IQ. When we communicate, the 3 types of communication. Number 1 is your verbal communication. That is only about 7% of your communication is verbal. About 38% of your communication is paralanguage. And 55% of your communication is non-verbal or body language. When you communicate, don't use much of but and. That sometimes
And is good. And is desirable. And is desirable, Simil. If you will use and, you will have more solutions and more options.
Okay. But don't use much of but.
But is not a good word.
Don't use much of no.
Yeah. So like Dr. Soma was saying, instead of saying but, you say sorry, but sorry, I have another way of seeing it. Yeah.
Avoid using the words like tu, tum.
Very
Use
good.
always respectful words.
Absolutely.
Do not 50% when you communicate, 50% of patients will not understand whatever you are talking. So it is very important.
You have a lot of good notes. So I want Aparna to take it further. Aparna, what is your take after what she's?
Yeah. So ma'am, you talked about the body language, where you say that face is the mirror of your mind. And also, when you're making an eye contact with the person, it has to be always, when in a professional front, it has to be always the eyes and above eyes portion. And also, we talked about touch. So touch should be an appropriate touch, but not a unnecessary touch.
In a respectful
And also,
manner.
and even appearance, which really it was a very nice point about the appearance. Because if you are a doctor, please you have to dress up as a doctor so that people should
wherever we are, don't take
whichever. So whatever. So if I'm a quality person, I have to be dressed up as so that people can recognize me that
Yes, absolutely. Yeah.
And also also
Anu, let Anu take it.
Okay.
Anu, what did we talk after this? What do you remember of today's session?
After dressing, we were talking about personal space. Like personal space is our bubble. So how much distance we have to maintain when you are talking with patient or patient attenders. We have discussed about that. And the most important thing nowadays, it is very valuable, valuing the time of a patient and patient attenders. So we have focused, like we have reflected a few points on how we can value the time of a person.
Wonderful. Thank you. So what else did I cover? Anybody wants to contribute?
We also discussed about the color, how color plays an important role in keeping in parity with the customers, that is the patient's current situation. That plays a very important role. So we actually discussed about the principles on communications, wherein they were quite takeaways and interesting one, and we have already discussed on some of the points.
So do you concur with what we have discussed today? Do you agree with what we have discussed?
Yes.
And do you also agree that these are very finer aspects of communication, and sometimes we are not very mindful of them?
Yes, it's not most of the time we are not very conscious of how we talk or act. So we have to be conscious.
Everything, our appearance, our dressing, our conduct, our behavior in public, our tone of voice, the selection of words. So we have to be very, careful, because everybody is observing and seeing us, and then it becomes very important to remember that I'm not only representing myself, I'm representing my hospital and my profession. So healthcare in total is, the target. So we have to be very careful to represent a good picture of our profession.
Ma'am, we also spoke about written communication and the loopholes which we come across. And we also spoke on we gave emphasis to tone and how it largely affects how our speech is perceived.
Wonderful. Thank you so much. So what questions you have about today's discussion?
I have a question.
Yes, sir.
So people in authority positions, their tone and voice tend to become more authoritative and sometimes aggressive. So to an outsider or someone who is very new and communicates with them, they perceive that as a sort of rude way of conversing with them. So are there any techniques to modulate the voice or tone, something like that?
So session 5th or 6th, we will be talking about styles of communication. And in that, I will introduce you to different styles of communication we all, use and implement in our day-to-day communication. All of you will get insight about your communication style. I'll be sharing a questionnaire which you will be taking, and then you will have to keep a note of the scores with you, and then we will be discussing your scores. So you will get to know about what are the different styles, what is your style, and then what is right and wrong about your style, the advantage and disadvantage of your style. And then as a result, you will be able to see that if I'm using a wrong style of communication, what will be the consequence? What will be the disadvantage of that? So automatically, I think once we become aware of our own lacunas, we learn how to work on ourselves, because acknowledgement is the first step towards improvement. That is one thing. Second is, if I am at a lower position and I have a higher up who is using an aggressive tone of voice, I may not have that, opportunity to say, sir, you can't talk like this. But then I will be talking about so many ways where you can make the other person, aware that that's not the right way of talking. So one example that I can give you here, which will give you a thought, food for thought. So my husband, as I said, he's an ophthalmologist. So when he was doing his post-graduation, I'm talking about almost like 40 years ago, he said a new associate professor joined who had done her MS from AIMS, and then she had done her FRCS. Very young lady. She came to the department, and they had a lot of seniors. So she was probably fifth or sixth in the line. So she had a lot of people, senior to her. So he said a lot of time people, they throw their weight around, because she had done her MS and she was from AIMS, and then she had done FRCS. So naturally she was very knowledgeable, intelligent, and very well versed with what was later. So he said this, and I think till date I remember, and I really like the way he explained. He said, first I'll say in Hindi and then I'll explain in English if it is not clear. So कुछ लोग दूसरों पर भारी पड़ जाते हैं, है ना? कुछ लोग दूसरों पर भारी पड़ जाते हैं. He said, मुझे उसका प्रोफेसर का नाम भी याद है, but I will not take her name here. कुछ लोग दूसरों पर भारी पड़ जाते हैं, पर उस प्रोफेसर ने दूसरों को हल्का महसूस करवा दिया. Vijay, do you want me to explain in English?
No, ma'am. It's
No.
fine. Follow Hindi.
Yeah. So that I'm happy that this was a little difficult thing to. So she made them feel light in front of them. So a lot of time when you cannot tell your senior that that's not the way to behave, your good behavior should come as an answer to that person's poor behavior. But we will talk about it at length, and there will be many opportunities where I request you to bring up such kind of situations, because I know these are the difficult and real life challenges you all are facing.
Yes.
But then how to assert, where to assert, what is the right way of asserting, and is your understanding about assertion right? You will get to know when we will discuss about this in the forthcoming sessions.
Thank you.
So I'm sharing the feedback form right here. I request all of you to complete the feedback before we close. Give me 1 second to share the feedback form in the chat box. I will put. I've shared this feedback form in the chat box, please. So the next session will be on how do you go about designing a program. Since it's a master trainer program, so I want you to talk about the training modality so that we learn how to go about designing a program. So whatever questions you have about it, we can discuss. Especially try to look at this session from the point of view that wherever you are working and whatever audience you have, because initially whatever you are learning, it's good if you start implementing and training in the existing setup. Tomorrow, of course, you can get an opportunity to do trainings across the country. But to start with, I think it will be best to start implementing in your existing setup, and then how you want to design, whom do you want to target as your audience, what all can be done. You can discuss all that in the next session. So I have received 8 responses. I'm waiting for some more to complete, and then we close the session.
Meanwhile, ma'am, shall I talk something? Nothing related with this topic, but of course, something related. Because you are sharing some prescriptions. So as someone coming from government setup, I'm not amused to see that, because on a daily setup, I am observing this kind of prescriptions. Even though we know this is not the correct way, but we are finding it difficult because of the volume of patients and the scarcity of time. We are finding it very much how to correct. So documentation, as you correctly pointed out, it's very important. This kind of, because what I felt like saying is that out of those prescriptions you showed, in my experience, those were better ones from what I am seeing. So I don't want to hurt anything, but simply I was saying those were better ones in a comparing in a government setup. I was just thinking it in that way.
But Dr. Bijay, the concern is it's a very huge safety threat. We
Yes,
have
you are right.
seen a lot of, I don't know how many of you remember that case of Ahluwalia, that child Ahluwalia, who received chloroquine in the IV. And that child went into cardiopulmonary arrest, instantly, and led a vegetative life. I mean, I'm sure you will also know hundreds of such examples. So I think that's where we should understand that we can't play with somebody's life, saying that I don't have time or the workload. What I want to say to everyone, please start practicing kappa. Kappa is corrective action, preventive action. That's the only way to refining yourself. See, even if I have huge volume of work and if I'm doing such mistakes, trust me, you will be the one who will be facing the brunt of the situation, unfortunately, if you're caught for that reason. There will be no escape. Law is very stringent. I mean, we know the consequences that we are seeing happening. So we have to find ways. And somewhere I will be also talking about design thinking as a way to improve your functioning. I'll be talking about that as a tool. Why I'm introducing these tools? Because we have to become good at management. Problem with clinicians, of course, now young clinicians like you are very open to learning new things. If I talk about oldies, they think we know everything and we don't need to learn. I'm really very happy and glad to have people like, Dr. Soma and Dr. Sambaji, because in spite of it that you are already very experienced, but you are open to learning. Clinicians need to learn management. It's not that you become manager if you learn management. But if I want to be a good, homemaker, I need to have good understanding of kitchen. I may not be cooking myself, but I should know how the cooking happens and where all can failures happen. And I need to be same way. If you all learn how to manage, then nobody can fool you. You will know how to improve your functioning. That's the message I want to give. And some of the examples I showed you were not just government setup sets. The third one, that was from a private doctor. And you are charging 800 to 1,000 rupees to your patient. So I can't give this reason. And I don't want to share my personal experience here. I lost my mother after bypass surgery. She was operated. She was very well, doing very well. She was prescribed some medicine, but she and my family was not explained that there are some medicines that you don't have to stop unless you talk to the doctor. This was not explained to them. Unfortunately, she stopped anticoagulant. And then in 3 months' time, she went into stroke and on bed for 3 months and she passed away. You may say the patient was wrong. I don't know who was wrong. Somewhere we failed. I would put it like this. If that can happen, can I find a way that does not happen? I don't want to blame anybody. I'm part of you. But I want to say, if you start finding the way to improve your functioning, a day will come. Read this book, Atomic Habits, if you get a chance to read. How many of you have read this, Atomic Habits?
I bought it last week.
Wonderful. Read that book. It's a wonderful book by James Clear. It says, if you even start improving yourself 1%, which is doable, wherever you are, it is doable. You will be 37% different from what you are today.
What is the name of that book, ma'am?
Atomic Habits.
Atomic
Habits by James Clear.
Madam?
If you want a soft copy, I can send it to you.
Thank you so much.
I'm fond of reading on laptop or phone. I like hard copies, so I always buy hard copies. That's the problem. But I have sir has it already. Wonderful. Excellent.
Madam?
Excellent.
Madam?
Ji.
Sorry for the loss that you suffered. We deeply sympathize with you. And as a person who has been a clinician and an administrator both, I know the importance of how difficult it is to enforce clear communication or to implement it, especially when you have a vicarious responsibility. See, when you are facing your own responsibility, I have been a clinician for 3 decades, so I know that I'm responsible for my own work. But when you're in a position as an administrator and you have vicarious responsibility, it plagues you that all doctors and all staff should practice good communication, especially written communication. So there has to be a way to, spread the word and overcome the resistance so that we have better healthcare all around. Thank you for the efforts taken.
Thank you so much. I think bringing, to have brought this issue, I wish we had time. I could have discussed with you, and we can never change everybody at one go. So there are strategies. Read about skill build grid, and you will get to see how you can implement change. So implementing change is another management tool. And as an administrator, if I don't have that tool in my kitty, I will not be able to bring change. I have to learn how do I implement change. If I say problems are problems, then how am I better than others? I have to focus on solution. And when I started doing healthcare communication programs, people said nobody will listen to you. Nobody will be interested to do the program. And you will be surprised to know I did 500 training for just peanuts. But that gave me a lot of understanding of the challenges in healthcare.
Yes, ma'am. Change does come in slowly but surely. And even if we implement a percentage of change, we are slowly moving correctly.
Absolutely.
Thank you, ma'am. Thank you,
Thank you so much, everyone, for being patient and listening and also participating. I think I'm enjoying very much your participation and your contribution. Let's continue with the journey and we meet next week. I think there is one small situation. Jenna wants me to, go to Holy Family on 20th of March. That is Wednesday. So she has some challenge and she can't accommodate on 21st and 22nd. Is it okay if we move the session to 22nd? That is Friday. I'll put that as an poll in the group. You are free to give your, if you are
22nd of March, ma'am.
2nd of March. So instead of 20th, 20th, she wants me to come to Holy Family to her hospital. And I don't want to do 2 sessions in one day because it becomes too hectic to manage things. So I thought if we can move 20th session to 22nd of March, I'll put in the group. Please feel free to say yes and no. And if majority of people are okay, then we will do it. Otherwise, we will stick to the original plan. I hope that's okay with everyone. Thank you so much.
Thank you.
Good night. Take care. Thank you.
Good night, ma'am.